Good evening, everyone. We might make a start and we'll be able to welcome those that join us in the next few minutes. But welcome to our fourth ECHO session of the Enhancing Palliative Care series. This session will focus on advanced care planning, the key elements of providing good end-of-life care in the community, and the Resuscitation Plan 7-step pathway, as well as the latest update about voluntary assisting dying implementation in South Australia. And that will be presented by Chris Moy. I'll just share my screen so that we can start. So just bear with me. Okay, so as I said, this is our fourth session. Welcome. I'd just like to start off by acknowledging country. I'll just go back. Yeah, so we'd like to acknowledge the Kaurna peoples, who are the traditional custodians of the Adelaide region. We pay tribute to their physical and spiritual connections to land, waters, and community, enduring now as it has been throughout time. We pay respect to them, their culture, and to elders past and present, and would also like to acknowledge and pay respects to those Aboriginals and Torres Strait Islanders people from other nations who live, work, travel, and contribute to Kaurna country. So as it says, welcome. As you know, having been on board for the 4 sessions, this project is supported by funding from SA Health through the Palliative Care 2022 Grants Program and is being delivered to you by GP Partners Australia. Just a little bit of housekeeping. Please introduce yourself in the chat. Let us know where you're joining from and your role. Your microphones are muted, but there will be lots of time during the session for questions and discussion. You're welcome to use the chat function to ask questions if you have any comments or having any technical difficulties, but also feel free to raise your hand. The didactic session will be recorded and will be emailed to you within the coming weeks, as we've done in the past. Please remember not to disclose any personal health information during the session. And as always, we hope that you really enjoy the session. Our general ECHO session works with introductions, as I'm doing now, and then we'll have the didactic presentation, and then our interactive case-based presentation for discussion. We'd really love you to submit a case, and if you can do that, you can let us know in the chat, or you can email at my email there on the screen, or you can also let us know via the website link. And also that prompts just a note about our website. The website has a designated Palliative ECHO page, and on that is all the resources as per each session. So please take a look and access what you need to help you. So without further ado, I might hand over to Russell Shute. After, I think, actually, we'll probably just go around the table and introduce ourselves as we've done in the past. So most of you know myself. I'm General Manager here at GP Partners and leading this ECHO session. And I'll just go to my right.
Hi, I'm Atif, and I'll be providing the IT support for tonight's session.
Hi, I'm Naomi, and I'm the network coordinator and look after the website management.
Okay, Chris Moy, yes, I'll be doing a presentation on end-of-life care and also voluntary assisted dying. I've been involved in this area for a fairly long time.
Andrew Noble, extended care paramedic team leader with SA Ambulance.
And I'm Russell Shute, GP advisor to the program. And
And over to you.
And over to me. Okay, well, should we get maybe Olivia wants to introduce herself?
Oh,
too?
and Julian,
And
they're
Julian.
online, yes.
Is that okay? Olivia, are you happy to introduce yourself?
Of course. Hi, Olivia Rygorowicz, freshly minted palliative care consultant.
Julian Soriano. I work as a palliative care project pharmacist at Salin, as well as an embedded aged care pharmacist in Tanunda.
Fantastic, thanks guys. So we're very lucky because we've got input from different people that have different interface with palliative care. So and hopefully throughout tonight These different expert voices can help us navigate some of the challenges from Chris's teaching and also the case that's going to be presented later. Yeah, welcome to everybody again. I'm going to introduce Chris Moy now. I'll make it brief because Chris asked me to make it brief. Chris is very well known to most of us because he was a familiar face on television during, the early part of and through COVID, presenting balanced and useful information as we all tried to navigate a very difficult time in his role as Vice President of the AMA. But of course, he's a GP at Archivar Medical Centre, and he's also been involved with developing the 7-step pathway and advanced care directives and various other things, and was one of the GP advisors to the GP Palliative Shared Care program. I was lucky enough to work with him then. So, Chris, thank you very much for coming along and welcome.
Thanks so much, Russell. Look, today what I thought I'd do is give you a quick run through, just to some degree, hopefully a bit of a reminder about some of the key elements about end-of-life care, particularly with regards to legislation in South Australia, which supports really good end-of-life care. And then after that, in my role at the moment of being the chair of the Voluntary Assisted Dying Implementation Task Force, talk to you about very big changes with respect to end-of-life care, which are going to be affecting us all, whether we actually want to be involved or not at the end of January. So look, I'll start off first, if you don't mind. I'm going to share my screen, and we'll just firstly talk about end-of-life care first, and just walk through what a lot of general practitioners have to deal with quite often in the care of their patients. So look, the first thing is I will talk through the eyes of a particular case. We'll call her Dorothy in this case, common situation where you have a 78-year-old woman who lives at home with her husband, has a supportive family, but she has rapidly progressive lung cancer, but there's no curative treatment available anymore. And then, she says, well, I'd like to stay at home to die. And that's often a very request which sends shivers up even my spine, because I know how much it takes to actually keep somebody at home and to try and, to our greatest degree, keep those wishes. I must say, I never promise that that's the case. What I do say is we'll do our best, but we do understand what your wishes are, because we understand the logistics, and really sometimes it is not practically possible to keep somebody at home. So we'll talk about the obligations in the law, converting a patient's wishes into clinical instructions. If the person's up for resuscitation, how are you going to actually manage to look after this patient and try to put things in place to ensure that everything goes to plan? So, the first question is always, what really is my professional obligations in providing care, end-of-life care for Dorothy? Now, a lot of people sort of think that, well, obviously my job is to save people, but what's not clear, understood by many people, that even within the professional standards, the code of conduct, which the medical board governs by, has very clear statement that we do need to understand the limits of medicine and prolonging life, and recognise when prolonging life may not benefit a patient, and understand that while you don't have a duty to prolong life at all costs, and you do have a duty to know when not to initiate treatments and to cease attempts when they're going to be of no benefit, while ensuring that the patients receive appropriate relief from distress. And I think that's the bit that a lot of people forget, that really they're worried about the yes or no about keeping people alive, but forget about really our job is to make sure that people don't suffer at the end. Sorry, excuse me. Now, one of the questions is, and I hope you all know now in South Australia, what the legal the one good thing in South Australia we have one legal document, and there's a legal document on which Dorothy could write her wishes if she were to lose decision-making capacity, and that is the Advanced Care Directive. Now, many of you who have been around for a long time, there are all these other documents: medical power of attorney, anticipated direction, and injury guardianship, but that all got coalesced into the Advanced Care Directives in 2014, and there's a separate document which is the powers of attorney to do with financial matters. Now, the key thing about advanced care directives is what a person can do is that they can either appoint substitute decision makers, call them SDMs from here, or they can write down their wishes, instructions, and personal values, which apply any period when a patient loses decision-making capacity. And that's really important. That's the time this document goes into effect. And on this form, an advanced care directive they can appoint the substitute makers. And I think the best way to think about a substitute maker is that they basically become the person if the person cannot make any calls. They become the person. So if I appoint my wife as a SDM or substitute maker, before you do anything to me, you have to actually ask her before you do anything to me. The next thing is that in South Australia, it's very clear that substitute makers can be appointed to act individually or together, but health practitioners only have to contact the first substitute maker that can be reached. It's up to that substitute maker to sort of make a group decision if that's what's required. They can put non-binding requests, which are things like, which are advisory. They're not binding in that some things are not reasonable. They can't put things like, I want to live forever. And they can't write things like, I want to die on the Queen Elizabeth II if they haven't got the funds, because they're not reasonable. But what they can do is write binding refusals. And these are things where they refuse treatment that you may offer, and these refusals must be applied if you believe that they are relevant to the situation. And that's really important, if it's relevant to the situation. Now, the thing about this is, and it's important to understand, and this is going to be very, very relevant during voluntary dying, is about this issue about decision-making capacity, because a lot of people get a bit confused about decision-making capacity. They think it's a medical condition that you have to do a mini mental, or you have to do, and you have to drug alcohol test can tell you alcohol level can tell you whether a person's lost decision-making capacity or not. It's not a medical decision. And it's really a question of whether a person can do certain things, and we'll go through those in a second. But the important thing is it starts from a position of presumption. You don't assume somebody's got has lost decision-making capacity. You presume that they do have it, and then you actually have to, if you're worried about it, prove that they don't have it. And in doing that, first up, you need to understand that impaired decision-making capacity only relates to a particular decision. It's not about, you can't just say because they can't make one decision, they've lost all decision-making capacity. You should try to support the decision, but ultimately it means that they can't do one or more of four things. And it's really common sense. It's really whether they can understand relevant information, they can retain information long enough to make a decision, use information to make the decision, that means weigh up risks and benefits, or communicate the decision in any way, not just in speech or writing. And so if they can't do one of those, that's when you say they've got impaired decision-making capacity, and that's where an advanced care directive would come into play if one was available. Now, the thing then is, like, and this gets confusing. A lot of people say, what is the main thing you should be considering in making decisions for Dorothy if she's lost decision-making capacity? And for, when I do a lot of teaching, a lot of people, younger doctors particularly, get quite confused because they get information overload. And they get caught up with these ideas that, my only job is that life is sacrosanct, and what are the clinical parameters that this person will be at the end of their life, or what's this protocol in the situation, what the textbooks say. My job is only to save lives, what's best for this patient, and that's something we all do a little bit of. What's the legal situation if I don't get treatment? Maybe I better keep trying to keep him alive, or otherwise I'll get sued. His children are saying we should let him go, but his wife is saying that we must keep him alive. What do I do? What's this? I don't know how to tell them bad news. I need to give them hope. Maybe I'll give them one more round. And what's this bit of paper, an advanced care directive? What's this plan? And who's this person calling themselves a medical power of attorney? Who do I listen to? But the key one is this: what would this patient have wanted had they been conscious? And this is called a substitute decision-making standard. That means we tried it, or you should actually be doing this. And I think sometimes, in amongst everything else, it's very easy to get lost with that view. And so the first principle about the Advanced Care Directives Act and Advanced Care Directives is that all of us should be deciding as if we're in the patient's shoes at all times. We try to put them in insurance shoes in that situation and make the decision that they would have made. Now, the next thing is that, when you've got a crowd, you've got a family conference and everybody's in there and everybody's shouting what they want. You've got the son who's come from overseas and seen Dorothy for 5 years and says, this is what we want done. And then he's guilty. And you get the other people in the family saying, well, no, we need to support her. I mean, who should we rely on to obtain consent for treatment if particularly somebody's lost decision-making capacity? Well, there's actually a consenting hierarchy, which I have actually sent in. It's available, should be available through the program called the Consent to Medical Treatment in Healthcare Adults, which is a very clear consenting hierarchy in South Australia, which exists, which is supported by the legislation. And that means if a person's got decision-making capacity and you've got a family conference or you're trying to make decisions, who cares what anybody else thinks? It doesn't matter. Nobody else matters. only the patient matters. The second person, if the patient can't make a decision and they've got impaired decision-making capacity, then the thing person is a substitute decision maker, which is they're the second ranked. Below that is any wishes in an advanced care directive, which are relevant to the situation. And below that is a group of people called persons responsible, which are either a guardian appointed by SACAT, or was the guardianship board, or a spouse or domestic partner, adult related by blood or marriage, or an Aboriginal Torres Strait Islander kinship marriage, who is, most importantly, have a close and continuing relationship and is willing and able to make the decision for the patient. And below that is a friend who has a close and continuing relationship and is willing and able to make the decision. And then below that is somebody like a DON of a aged care facility, except they can't make decisions about restraint and things like that. And below that is the guardianship board if we have to go. But I suppose understand that there is actually a legal hierarchy of decision making, and you don't just pick out the first person, and not everybody is equal in a family conference. Not everybody is equal in a family conference. And frankly, you know, you need to understand that when you're doing an advanced care directive, you're giving certain people certain powers that will outrank them in terms of decision-making capacity, usually decision-making capacity. What should you do if there's a dispute about treatment to provide for Dorothy? Well, there is the Office of Public Advocate, and I just had to do this over the weekend, actually, where there was a bit of a fight on about this. And the Office of Public Advocate can be called, or else you can actually direct the person who's mad at the situation to the Office of Public Advocate to try and adjudicate on situations. And they can actually give adjudications on situations where there may be dispute about whether, you know, what should be happening and who should be making the decision and what decision should be made. Because there are always problems. I mean, I think that's an important thing to understand. End of life situations are really emotional, and it's it's almost impossible to always avoid conflicts, and it's not your fault. Okay, it's sometimes you're walking into family situations that have existed for many years. Now, there's a couple of points which are really important because they may be hopefully very relieving to you if you really understand. South Australian law, forget about voluntary assisted dying for the moment. South Australian law has always been really good at protecting life care because it does two things. The first thing is, the question always is do I have to, can a family force me to provide Dorothy with futile treatment? And I'll just want to reassure you that South Australia has really, particularly back from 2014, the law was changed to make it very clear that there's no requirement. There was a change to the Consent Act, an amendments to the Consent Act, which went along with the Advanced Care Directives Act, which means that you do not have to provide treatment of no medical benefit to a dying patient. Okay, and that means you don't have to offer 50 options. You know, the option, we often do that. We give every single option, but the options which we don't want, which are not of benefit, we're still giving them because we're scared of medical regrounds. You only have to offer treatment of medical benefit. And look, I don't want to go through the changes, but essentially what the legislation says in 17.2 of the Consent Act, it says that a medical practitioner responsible for the treatment or care of a patient in the terminal phase of a terminal illness is under no duty to use or continue to use life-sustaining measures in treating a patient if the effect of doing so would merely to prolong life in a moribund state, whether or not the patient or the patient's representative has requested such measures to be used or continued. I think that's really important to sink that in. You do not have to provide treatment of no benefit, and that includes other people. Like we've got Andrew here from the ambulance. If it's futile, they do not have to continue. The second thing is that the other question that's always is, and a lot of my colleagues come up to me and get very scared about giving morphine quite often. Will the law in South Australia protect me in giving Dorothy enough medication to make her comfortable? I can reassure you that is definitely the case. Again, it's Consent Act 17.1, that's the section just above the one I just talked about, is a medical practitioner responsible for the treatment or care of a patient in the terminal phase of a terminal illness incurs no civil or criminal liability by administering medical treatment with the intention of relieving pain or distress, even though the incidental effect of the treatment is to hasten the death of the patient. Let that sink in. That means you give adequate treatment to maintain their covenant, even though the secondary effect may be that they may die. And the biggest thing is always morphine about respiratory suppression, although I think that's actually overrated. But this principle is called double effect, that you can be treating the symptom, but it may have caused hastened death of the patient. But, you know, honestly, it's better. Bottom line is you can give them enough stuff. But then there's always this thing, okay? Now, it's interesting, we'll talk about VAD in a second. What is the difference between euthanasia and palliative care? And this is the thing that everybody gets really scared of, because a lot of people say, oh, no, I don't want to give it too much morphine because I might knock them off. Well, the difference between euthanasia and palliative care is very different. There's a big difference. And voluntary sedation palliative care, the big difference is the intention of treatment. And that the sort of terms I think of it is, you know, in football terms, and I love my footy, but when you're playing football in palliative care, the intention is symptom control. You're solely focused on symptom control, and you're basically going for the ball. Let's call that symptoms. Whereas in voluntary dying euthanasia, you're tackling the person. You're intentionally trying to end their life, and that's the big difference. Now, people go, well, how honestly? Well, firstly, documentation is a good idea, and telling the patient and family that that's what you're doing, but also deciding whether you can sleep at night with what you're doing. And I think the other thing in practical terms, there's a difference between what you do with doses. I mean, if you give it somebody, you know, if you think they may need 10 milligrams and you give them somewhere 10 to 20 milligrams, 12 milligrams of morphine, well, that's palliative care. But if you're giving them 100 milligrams when you think they need 10, that's going to be euthanasia. It might be homicide, actually, to be frank, but that's a separate thing. So, I mean, look, I suppose the thing I want to say in South Australia, we've got really good legislation in terms of a very clear principle that we try to decide as if in the patient's shoes. We have a very clear consent hierarchy about who you have to ask to get consent of the patient. You know, and the next thing is we've got a dispute resolution process called public advocate. There is legislation very clear, and we are the only state with both of these. Explicit legislation says there's no requirement to provide treatment of no medical benefit, and that you're particularly giving enough medication to maintain the comfort of the patient. So we really got good, so we are actually able to really focus on good end-of-life care. The problem is that there's this issue. Okay, it's all good if a patient has advanced care directive, but then there's always this problem. They write something like, I do not want to suffer. Now, poor old Andrew here from the emergency department, if they turn up in the middle of the night, right? Or if it says it's got advanced care directive and the poor nurse who's on the ward at night has to look at that and they go, what the hell does it matter? It's not very good because it's not very clear with instructions. So what can you do to change this into something that's useful? And this is where the work, so I was on this end of life working group after advanced care development, which really understood that we understand advanced care directives, which are really representing what the patient wishes. They basically represent you when you can no longer speak. But there's also a thing called Resuscitation Plan 7-step pathway, which again, there will be, and there's a version, it's a community version which is available, which is for the responsible clinician to convert these wishes into usable clinical instructions about resuscitation and end-of-life care. And this is what it looks like. And this was actually designed mainly kind of from my work in the aged care facilities about just what the steps you have to go through to make a decision about a patient, whether to resuscitate them or not, whether you're going to give them more aggressive treatment, but also making sure that we give them palliative care if they don't, if you're not going to do anything, because it's all very well to make a yes or no decision. It's really important to make sure you follow through to make sure they don't suffer. And so, trigger is, it's got a set called trigger. Is there a trigger to have a discussion? Do you have enough, assessment is, do you have enough information to have a discussion? Consultation is actually consent hierarchy. Who did you actually get the consent from? Resuscitation plan is actually the treatment bit, and it has, is the patient not for any treatment aimed at prolonging life, or is the patient not for any of these things, like not for CPR, not for invasive ventilation, not for intensive care treatment? But then ask, if you're not going to do this, if you're not going to resuscitate somebody in the middle of the night, or if you're not going to send them to hospital, what are you going to do? You're going to make sure you write a palliative approach to care, and it has a not for hospital transfer. And importantly, it says not for hospital transfer unless palliative care measures fail to maintain the comfort and dignity of patient or resident in their place of residence. And that was designed because a lot of my residents that I look after, those people who just don't want to go to hospital, but they get shoofed off anyway because they're worried about medical, the nurses are worried about medical legal things. And then transparency is about talking, did you speak to the right person? And then this form is can be made indefinite. Now, a lot of people think, well, what was this designed for? This was actually to replace those NFR orders that people used to write, and they are so dodgy because often they were written without anybody talking to anybody, including the patient. And it supports a clinician in making through the clinical, legal, and ethical steps of making the order. And it does ask, what are you going to do to maintain the patient's comfort and dignity if the patient's not resuscitation? And that's important. It takes us to the next step evolution of not just being caught up about what we're not going to do to somebody. It talks about what we are going to do for somebody, and that we don't abandon them in end of life care. And that for me was actually the more important thing, because I think we get so caught up and we get such a bad name. Unfortunately, doctors do get a bad name for not giving enough morphine. And to some degree, that's actually driven a lot of the drive towards voluntary dying. It's not, it's what we don't need enough form. People go, we don't need enough. Doctors say, oh, we don't need enough form. Well, actually, it's an NFR order with a process written around it. It helps doctors make the right decision. It protects both the patient and doctor. It's a standardized document, and there's versions you probably have got from hospital, and it's transferable across all sectors, and that's important, and includes the not for hospital transfer order. And also understand that ACD is really for the patient. This form is for doctors to try and convert those wishes into usable instructions. So just a few little tips now. If the patient's for not resuscitation or curative, what are you going to do to ensure their comfort and dignity? Well, I'll just throw, look, you can look after a patient yourself. So Dorothy is somebody you can look after yourself, but sometimes I much prefer working with the palliative care services, what we call shared care, but really working in collaboration with them, because I think I bring a lot, but the palliative care services bring a lot as well. And look, there's some really great resources in palliative care as well, like the therapeutic guidelines, Care Search, Palliative, which is an app you can download, which gives you resources. And also, I'll just run through a few prescribing basics about opiates, which a lot of people may be useful to you. It makes just a few little tips. I find that prescribing of opiates is based on thirds. The word 3 comes into it, the number 3. So in starting opiates, it's usually best to look at something like morphine, small amount very frequently. So something like 2.5 milligram of morphine syrup 1 hour in PRN is the sort of thing that you might start, 2.5 quite often. And then what you do is you have small amounts frequently, and then after a while you convert it to long acting once you've worked out how much a patient needs by just adding up the doses and converting it to long acting. The problem is, as you increase doses to long acting, patients need more over time. And then the breakthrough doses have to be changed. So it's 1/6 of the total daily dose, 1 hourly. And there's the other thing about changing opiates is just another little note. When you change from one opiate to another, there's often a problem because you use those calculators you may see around the place, those opiate conversion calculators, but you've got to reduce the dose by 30% if you change to another opiate, at least, because of the thing called incomplete cross tolerance, because you actually get you get used to one, and then when you switch over to another, you're not two, so you actually overdose them on a new opiate. And also, when you convert to subcutaneous morphine, how you do that, which is often the case when a patient no longer can take oral doses, you divide the oral dose by a third. And just a tool to assist you in prescribing, there's a thing called, and particularly we're talking about subcutaneous medications. This was designed from the 7-step pathway because we knew a lot of people didn't feel comfortable prescribing, particularly subcutaneous medications in aged care facilities. This anticipatory prescribing protocol, which is an SA health document, helps you prescribe things to put in the PRN medication list, say in an aged care facility, but also the sort of things you can help you ordering medications for a patient at home as well. So it's a tool worth looking at, and I think it should be up on every nurse's station and every aged care facility, frankly. Look, really good to work palliative care services. That's really important. As I said before, I work very closely with them. And look, just a few other little tips in end of life care, which is some suggestions. Family conferences are really good, but as I said, you need to know before you walk in the room who's got the legal ability to provide consent. It's really good to put all information together at a person's home, and that includes like a medical history, contact list, 7-step pathway, advanced care directive, medication list, so that if they actually end up in a situation where they need to call an ambulance service, they can actually look at this and potentially work with us. And I've got a little line about extended care paramedics, because they're in a position to actually start palliative care and actually potentially keep a patient at home, but they need a background. They need some history before they can actually start this. And I think the other thing is just to really anticipate when your patients will need, what your patients need, because it requires sort of a little bit of forethought sometimes. There's a bit of an art with palliative care, because it requires you to kind of think not just what you need, what the patient needs, but what the next person who may have to look after the patient in the middle of the night needs in looking after the patient. I'm actually going to stop there and actually just go flip over.
I have a question.
Yeah, shoot.
So, there's a question from Jennifer Wilson, one of the people online, and it's, can you please clarify if the hierarchy is relevant if there is not an advanced care directive?
No, so that's why it's a hierarchy.
Right.
So essentially it works like this. You go down, and if you've got a substitute maker and they've been appointed, so a patient's no longer got decision making capacity, then the substitute maker, and it's available, and the substitute maker theoretically legally has to show it to you.
Right.
They should actually, you can ask them to prove it. Then they are top of the tree. Then below that is the wishes. But the problem is that sometimes a patient doesn't have one, they've never created one, but also the person, substitute maker, is not available, or the ACD is not available. Then you go down the tree. So when you go down to the person who's responsible is when a patient doesn't have one, or it isn't available, it isn't seen.
Yeah.
That's when you go to the person responsible. So essentially you go down the tree and you try to find the one that you can get a hold of that's the highest up the ranking.
Right. So it's still okay. So it still applies. The hierarchy still applies, and even that's
the hierarchy should, as long as we can find the person.
You've got to find the person, right? So if you're so if you're in some situation where somebody's interstate, you cannot find anybody. Then it goes to the person responsible. Yeah, okay. Right.
You don't just grab the first person next to the person. You go to the person responsible, and sometimes it takes a bit of work. You might have a family and friend there, and sometimes actually it may be the person that's high ranked as the person that's the closest. You know?
Yeah, okay.
You actually need to. Yeah.
What happens with you, Andrew? Do you find that this has been a problem that you encounter?
Yeah, really regularly. So to put it in context, extended care paramedics, our mandate is to treat people and avoid unnecessary ED attendance or hospital admission. So palliative care fits perfectly into that. We are the specialist palliative care after hours home assessment and treatment capacity. So we try and fit very hand in glove with the way in which they work. Look, in my experience, advanced care directives are an enormous, or any sort of anticipatory directive in the broader sense is an enormous benefit, but they are almost always either a little bit too specific or a little bit too broad to act on very specific, very literally, very exactly. But they give you a really good idea of the vibe around the person. I think that they're influenced a lot by when they were written. We find some were written really anticipatorily when someone was absolutely fine, and it's a really difficult task to try and conceptualize why would I not have decision-making capacity? What would be going on? They end up way too broad. Well, not too broad, but they're of limited value because we're talking about just I want to be comfortable. That's actually probably about as useful as anything. To a degree, we have to act on good faith as much as ideally we would like to see the document. I should say that, and so we're typically going into a crisis situation where there's a very sudden deterioration and inability to swallow, and we're having to transition them onto parenteral medications or an unanticipated terminal phase of the terminal illness. So people don't always have the paperwork there. To a degree, we'll rely on the doctrine of necessity that if something has to be done and it seems reasonable, we will. Invariably, though, I find we need to consider these sort of, especially differences of opinion that Chris was talking about. It is actually really quite rare that there is a fundamental difference of opinion, and more often than not, the difference of opinion is actually around legal obligations to persevere with treatment that is futile. And so I find a lot of those, and people's bandwidth in these crises is understandably narrowed. A lot of these crises are resolved with kind of medico-legal education about responsibilities of substitute decision makers, and helping them understand that they are doing the right thing by doing less for the patient because there's documentation that that's what the patient wanted. So yeah, getting the general idea of what the patient wanted, and then helping everyone understand how best we can achieve what they wanted, focused around comfort and dignity, basically, the two principal sort of directives. Yeah.
So have you seen much uptake for community 7-step pathways?
Oh, yes.
You have?
Yeah, quite a
that's
lot.
a good thing. Yeah.
To be quite honest, probably even more than in aged care.
Okay.
We still come across a form called a good palliative care form.
In aged care.
In aged care, it's really a not for resuscitation form, and that is the subject of a little bit of misunderstanding at times, where aged care staff, with the best will in the world, will just go straight to the good palliative form when the patient has decision-making capacity. And so we get less than accurate ideas as to what the patient wants, and then we go and talk to them. They tell us what they want. But yeah, no, there's been a pretty good uptake. Not universal, but no. Yeah.
Are there any questions out there? You can either pop them on chat or raise your hand. Or we're going to maybe move on to the next.
I'll just throw in one final point. I mean, with the advanced care directives, as I said, the way I think of it is it's people talk about loss of autonomy when they're older. It's the ultimate defense against that. And what you're trying to do is either appoint somebody who is going to be a substitution maker, and they become you if you lose decision capacity. Or you write down your wishes, particularly with regards to refusals. Now, the thing about it is, I think, if I appoint a substitution maker, they become me. But and this is something I advise people when they're filling out the advanced care directives, is don't necessarily appoint the one that just loves you the most. They may not be the one able to put themselves in your shoes and make decisions that you want. Because in a family conference, I often go in there and say, well, our job here is not to do what you want or what you think is right. Our job is to do what the person wants. And sometimes, the person that loves you the most isn't the one that's actually the right person for the substitution maker. And it's something that's a lesson that I've learned over time and tell people.
Just on that point, Chris, I think that's really, really useful, because it's a not uncommon experience that a substitute decision maker is aware of that responsibility to make decisions as though they were the person. But what they've given less consideration to is what sort of decisions are these that we're going to make? Because these are decisions about not persisting with feeding the patient, decisions about even not withdrawing, but not persisting with providing them with hydration because they simply can't process it. They're difficult decisions that without sort of educational support around the fact that physiologically, if the kidneys are shutting down, there is no sense in putting more water into the person. These are not, sometimes I feel like SDMs have not given as much thought as to what are those decisions. So yes, it might be best being that the son or daughter that loves them the most, but it's perhaps would be better being the son or daughter that is just the most calculating, most can maintain rationality when things are sort of going to pieces. Yeah.
And the flip side of that is when you go into a family conference, I've spent a lot of time working out who's got the highest up the tree. And obviously the person's got decision-making capacity. It's irrelevant what everybody else thinks. But quite often I actually spend my time trying to work out if there is an SDM, then they actually hold the keys to decision-making capacity if the person can't. Now, others in the room may disagree, but if they have to disagree, they have to convince the SDM. But the SDM has to hold, and you always walk in there and say, our job is not to do what we think is right. Because unfortunately, the son from overseas that hasn't been there for 12 months or 4 years and hasn't seen their father, hasn't done anything for their father, but comes back and then starts complaining about what everybody else is doing, is usually acting out of guilt. And so if they're not the substitution maker, it's really important that people have to hold their line. And it's not easy sometimes. And that's why I always say that we try to be sensitive, but unfortunately the reality is if we're doing the right thing for the patient, we are sometimes get in situations where there's still disputes. Would you like to go on to the next topic? Because what I was going to do, because I was appointed the chair of the implementation of voluntary dying, which is going to make the world change in just a few weeks, actually. And I think it's probably worthwhile just having a bit of a chat about where that sits at the moment, because it is actually going to be a somewhat changed landscape, even in a, as I said, even in a few weeks. So I'll go back to share screen again, and we'll just have a chat about voluntary assisted dying. So voluntary assisted dying in South Australia it's going to be implemented very soon. And just to give you some background, essentially, we've done that already. But look, essentially, this legislation was passed in June 2021, and it's called the SA Voluntary Assisted Dying Act. And look, it's coming now. The implementation was originally March next year, but the state government brought it forward to January 31st next year. So it's going to be implemented, and it may bring it forward if it's still possible, although it is going to be quite difficult. I was asked to chair the task force only from December, so we've only had about 11 months to implement this, and we've been working our guts out trying to get it to the right point. And we've got a task force, working groups, and an SA health team, which have actually been a very, very impressive team working to try and implement this in time. And the government is being very clear. And I suppose the thing about it is that the Act is very, very safe Act compared to a lot of the states. It's based on the Victorian Act. And it's got two halves. One is to make sure that people get access, they have this new choice, that it's accessible, there's equitable, but also that there's very strong safeguards in this Act to particularly protect those who from things like coercion. So very strong penalties for things like coercion, but also to protect those who may want to consciously object, and that includes healthcare workers who want to consciously object from involvement in voluntary assisted dying. Look, these guiding principles, which I won't go into specifically, but the things that I've been very clear about is the fact that palliative care is still there. The AMA, in my AMA role, we actually got it in there very clear that there may be voluntary dying coming in, but palliative care is still there. They're quite different based on what I talked about in terms of intention, but we may still need palliative care because the one thing that people have not really got into their heads yet is that voluntary dying is something that is only an operation if the patient retains decision-making capacity, remember that word again, right through the process until even to the point that they take the medication. So if they lose decision-making capacity at any stage, voluntary dying, the whole thing falls apart, and then you have to resort to that. This is why advanced care directives, 7-step pathways, palliative care still are really important in the background, because a lot of these patients, as you know, may still lose decision-making capacity along the way. We really want to maintain therapeutic relationships with a patient's doctor or other health practitioners wherever possible, even if those doctors, health practitioners may have conscious objection to involvement, because there's such a value in that relationship. But having said that, health practitioners have the right to have respect for their culture and beliefs and values, including with respect to conscious objection, but also if people want to be involved as well. And it's important, as I said before, coercion and undue pressure are really important. And this is why matters of decision-making capacity and making sure that people aren't coerced is really, really important in voluntary dying, because unfortunately there are vulnerable people out there, for example, the elderly and those who with disabilities, which are at risk of being coerced in this area. This is the setup. So I was the chair of the implementation task force, which is the third line down. So it's been a huge project for the government. And as I said, it's coming like a train. Now, I think I'll talk about three major things about it. The criteria for access to voluntary dying. So they're very, very strict in South Australia. To access voluntary dying, a person must meet all of the following criteria, which is that they must be 18 and over. They must be an Australian citizen or permanent resident and be resident in SA for at least 12 months. They have to have decision capacity in relation to voluntary dying right until they actually take the medication. And they must be diagnosed with a disease, illness, or medical condition that is incurable, is advanced, progressive, and will cause death, and is expected to cause death within weeks or months, not exceeding 6 months, or 12 months, which only applies for neurodegenerative conditions. So that's motor neuron diseases and things like that. And is causing suffering that cannot be relieved in a manner that the person considers tolerable. Now, medical practitioners, the Act only allows medical practitioners to provide voluntary dying. And it's the requirements are kind of interesting. The minimum requirements between there's two major doctors that have to, at minimum 2 doctors have to be involved, the coordinating medical practitioner and a consulting medical practitioner called. And in between them, they must hold a fellowship with a specialist medical college or be vocationally registered. So both of them must, but between them, one of them has had to have at least 5 years post fellowship, and the other thing is that one of them has to be an expert in or have relevant expertise and experience in the disease, illness, or medical condition, and that may still be a GP who has significant, expertise in a certain area. And both medical practitioners must complete compulsory voluntary dying training and be ticked off and be registered of doing so to be able to do this. And this is really important, and this is what's really interesting. Medical practitioners are prohibited from initiating a discussion about voluntary dying. However, they may provide information about it if a person requests it. So that straight is really tricky, because what we're really worried about, so this is very similar to the Victorian legislation, doctors can't bring up the subject of voluntary dying. And if they are, they could be reported to APRA and health practitioners actually. But they can only do it if the person brings it up unequivocally. Now, having said that, this is why in South Australia we've got a requirement in there that say that palliative care is quite different, and that includes double effect. We actually mentioned double effect. So you can talk to patients about palliative care, not be scared about it. You just can't bring up the issue about voluntary dying and the intentional ending of the person's life. And that was partly for coercion reasons.
But if they bring it up, Chris, in a
It's
consultation,
different. You document it,
you-
it's on.
yeah.
It's fine. Now, there's a thing called conscientious objection, and we understand that a lot of people are going to conscientiously object with regard to this, and we understand that. That's very clear. The legislation is very clear, but it actually has different levels of conscientious objection. The first is that registered health practitioners have a right to refuse to be involved in all aspects. All aspects. Health services establishments, and this is essentially going to be private hospitals, but other private health facilities, have to indicate, declare and be very clear about their conscientious objection. But if somebody is in a private hospital that wants it, they have to make arrangement in place to transfer the patient to another facility that may be able to provide it.
So I'm thinking the obvious is religiously affiliated organisations can
Health facilities.
health facilities.
Now, this is where it gets tricky.
So aged care as well.
No,
No.
I'm just about to get this.
Okay.
Residential facilities. This is where it gets real, and this is only relevant to permanent residents. In residential, they can actually have conscientious objection. Any person there can still, like the carers, the health providers, can all conscientiously object. But they can the facility, and they can actually declare that conscientiously object. They can even put it in their contracts. But they cannot hinder a person's access to the facility about information about it, and they cannot reasonably stop access to a person by a health practitioner or other lawfully participating individual, including witnesses, to documents and things like that, to enable requests, assessments, declarations, permits, and administration. So that means essentially that people can still have VAD on premises in an aged care facility, essentially, and all steps. And this is going to be a thing which is really very, very, we're actually, I think, as I said, the only state that has this at the moment, where, see, in other states, Victoria, my understanding is that facilities can conscientiously object to this not occurring on their property, whereas that's Australia. So this is going to be a big area for us. So there's a possibility that somebody could actually have this medication, take it, and not even tell us, which is going to be, we're trying to encourage people to tell us, but there is a possibility that people come on and take their medication or drug. There's quite a lot of steps. There's at least 3 specific requests by patient, and there is 2 doctors, a minimum of 2 doctors have to be involved before even you can get a final approval, and then you have to apply for a permit, and then you have to write a prescription, and then the patient can get it. And there's 2 types of supply. One is either by a self-administration or a practitioner administration, but practitioner administration is pretty much by IV, can only be done if a patient cannot ingest the medication or is unable to give it to themselves. And this is what it looks like. So this is what it's going to look like for a self-administration. Essentially, it's going to be a bottle with a powder in it. Patient mixes it up and drinks it. Okay, it's not going to be very tasty, so I'll probably have to take that. And there are some other tips that it's a bit more than that, but essentially that, and it has to be in a locked box, obviously for obvious reasons. For the patient has its own key. It's not one key. The pharmacy service has the other key. This is what it looks like for the practitioner administration permit. It starts to get quite confronting when you start to see what you're up against. So the doctor has to get IV access and then give these medications sequentially.
So what are they?
Sorry?
What are the medications?
I can't tell you.
Okay, right.
I cannot tell you at this stage.
I'm
I'm not allowed to, but I can tell
Right.
you, it's in the realms of, simple anesthetics and things
Yeah,
about
yeah.
paralysis and that sort of stuff.
Mhm.
Okay.
So 7 different.
Some of them are repeats
Agents.
because if
Ah,
the first time
okay.
it doesn't work, it goes.
Gotcha. Right.
Now, obviously, this is why it hasn't been something easy, and it was never just going to be released, and people think that it was just going to happen. But there's actually been several things that have to be progressed. There's a voluntary dying review board that will be put in place, and it'll be chaired by a person called Dr. Melanie Turner, and should be fantastic. There's a care navigator service because it's so complex. They'll provide support to patients and to health practitioners. Obviously, now we're limited by the fact that there's this Commonwealth Carriage Service law, which actually prevents us talking specifically about the use of the medications over phones or emails. So they're going to have to be very mobile. They'll actually have to travel to the person to be explained. And that's going to also apply to it's a VAD pharmacy service, which isn't going to be just your local pharmacy. It's obviously because of the expertise that's going to be required and the dangers. So there'll be a specific pharmacy service set up in South Australia, and that's been set. These are being set up as we speak.
Right.
And also there'll be voluntary liaison roles in public hospitals, all the LHMs as well, to help them as well set up. There will be a mandatory education package for medical practitioners, but also an overview education package for other health practitioners, but also the public as well. There'll be a VAD website with lots of information, and there's going to be a regional support program, sort of along the lines of PATS, to try and allow people, particularly with this carriage service thing, which is actually quite a big worry for us as we're setting this thing up, especially for the rural and remote. There'll be this VAD clinical portal, so most of the paperwork will be done online, essentially, although some things will need signatures, so there are some forms which we can't get around. I mean, bottom line is the legislation is the legislation, so we're sort of we have to hold to the legislation. Just to give you an idea of how many we're expecting, we're probably expecting somewhere near about 200 to start the process and maybe 100 odd to actually die in the first year. It's about 1% of all deaths based on the modelling that we've had. That's about the sort of numbers, give or take, in Western Australia and Victoria, which are the ones in the state which we're looking at. And the government has announced $18 million of funding for the voluntary dying program.
So, Chris, so that implies that, maybe I've misread that slide, but it's like a funnel. There's a number of requests.
Yeah, there's a lot of people.
There'll be a lot of people even after the prescription.
A lot of people
will go.
They can hang on to that medication for as long as they want.
Okay,
But for many people, that is actually a reassurance.
so that was going to be the question. Like, can they just go, I've got it. It gives me an option.
They can hang on to it. Once it's over, it's out of our hands. They can
Right,
hang on to it.
okay.
They'll have a key and they'll have the box. There might be an expiry date, but I don't know what that is at this stage. But essentially, it's up to them.
How do you know that they then access or use the medication?
Well, within the law, there's also a person called a contact person that's required. So if a person takes a medication, by law, that contact person is required within 15 days to actually return the remains of the medication. And then obviously the doctor would have to, there are requirements for death certificate, we haven't got time to go into, that there will be, to change the death certificate, which you actually have a notification, because we have, in the law, we have to notify both the coroners and the birth test and marriages that it's a VAD. Okay? Although the underlying cause of death is still the underlying cause of death. And it won't affect their insurance.
Right. Going to say next.
You've had some
Yeah.
very interesting
Yeah.
conversations with
Yeah.
lawyers.
This has been,
ethicists.
So this has been pretty heavy stuff for the last few months. Look, just to tell you, we've got quite a few practitioners involved already who are kind of interested in getting involved. But look, at the start, we were expecting some to be involved, and then it'll build up over time as people maybe develop confidence. But we understand a lot of people will never want to be involved in this as well, and it's really up to the comfort. The main thing is amongst everything that there is actually ability to. I suppose this is where I've come from. I walk into every meeting and say, look, we understand that people have very strong views about this. Number one, the law is the law now. The government have made a decision based on the will of the people through Parliament. The legislation is that it is. Within my group here, there's always arguments about how we should be doing things, and I say it's irrelevant. The legislation is legislation. Our job of the task force is to implement legislation as it is. There are things that have made it much more complex for us, but our job is just to implement it. What I'd say to people, and the final thing I always say is, look, it's time to stop people putting their own values onto other people. I mean, it's really important just to respect everybody and understand that this is coming, and it will affect, having said that, those people, including a lot of health services, even if they don't want to be involved in this themselves personally.
So if you're a GP and you're not registered with this, you know, a coordinating medical practitioner, somebody comes to you and goes, and I want to talk about this. How do you organise things?
So the first thing is document that they have actually done that.
Yeah.
You can make a decision. You have, if they ask you to be involved, then you have to make a decision within 7 days as to whether you want to be involved or not. Now you can contradict or not do anything beyond that, but beyond that, or actually declare that you officially that you don't want to do that. But if you do want to become involved, then you have to actually put in. That there's been a first request, right, and that you are going to be the coordinating medical practitioner. Now, before you can actually go on to what we call the first assessment or do anything more, you actually have to do the mandatory education and have passed the little test at the end, or you actually have had to done it previously and you'll be registered as doing so, haven't done so. So this education is mandatory and has to deal with a lot of stuff that I've just discussed there about what you require, what your so there's an education package, there's a clinical guidelines being written, which has been obviously quite extensive, and also a pharmacy. There's a separate pharmacy guide for the very significant complexities with regards to the medications, and obviously lots of information for patients. And then the process starts. Okay,
but if you don't, if you conscientiously, that's quite a word, isn't it, object, how do you then find? But you're happy to say.
Well, interestingly, in South Australia, and you know, we understand how sensitive it is, and some people conscientiously and hanging on to somebody else who would do it is actually too much for them anyway, which is understandable. So in South Australia, you don't have to do anything. You don't even have to refer them on. Okay. Now, having said that, there are penalties for certain things. One is specifically impeding somebody's access, right? Trying to coerce them out of it, or to impede there. We've seen people impede people before, like keeping on sending them on a route, right? And you can't do that. And we would hope that most people, and this is where this tricky thing is, what I find is that you may not want to be involved, but think about your patient and understand what they are. Don't abandon them. And if your action is just to hide in your own values, I think it's very easy for the patient to read at that point. And what I'd be saying is that it'd be great if people would actually, the general principle of assisting the patient, ideally, to be able to pass on to somebody else that could assist them, or at least send them to the Voluntary Assisted Dying website or to the Care Navigator service. So the Care Navigator service may then be able to help refer on to somebody else. But this is why I emphasize that first bit, because I know that a lot of people don't want to be involved in this. But what I would hope is that we don't just, our first action is to go, understand if somebody's asking for this, they're really distressed. Don't abandon them and just say, look, I'm going to be there for you, but I can't be involved in this. But this is what I would like to help you with this. Okay. And ideally, at least not give them no options at that point.
And it's the same process as if they were an inpatient.
So inpatient, well, look, it's the same thing. Any doctor is the same thing, they could request it within hospital as well. It is possible for them to request it in hospital, but I've talked about the various facilities. Private hospitals slightly different, and aged care facilities slightly different as well. But the health practitioner by themselves any health practitioner can consciously object to involvement to any part of it. So look, I mean, the reason why I brought this up was not because I think it's kind of useful actually having talked to you about what has been there and is still going to be there, and that's really important. It's the foundation, because we're expecting a lot of people, for example, to still lose decision-making capacity on the path. These are very ill people in the last 6 months of their life. Very many of them will lose decision-making capacity, and we really need those people to have an advanced care directive still and have a 7-step pathway Number one, they need the advanced care directive if they lose decision-making capacity. Now, they can't use an advanced care directive to follow through on the VAD,
Right.
right? Because once it's over, it goes into palliative care, right? But the other thing is what we really, and this is what's scaring the living daylights out of me, is if somebody is wants volunteers dying, they have their little bottle, right? They go to an aged care facility or they go into hospital, right? And they don't have a 7-step pathway, right? They don't tell anybody. They take the medication, and some poor bastard starts jumping on their chest.
Well, I wanted to ask you, Chris, is there, we already as an ambulance service, as paramedics, find ourselves, well, we go to a lot of cardiac arrests, and there are, it's not uncommon that someone's made an advanced care directive, nominated a substitute decision maker, whether they have a life-limiting illness or not, they've quite reasonably made a decision that if my heart stops, I don't want to be resuscitated. Everyone freaks out at the time, forgets. Now, our standard sort of approach to a cardiac arrest is that you start resuscitating and then ask questions, because we don't want to leave it too long. Will there be some sort of method of indicating on scene? I can picture dad sweets the medication, child comes around, perhaps doesn't know what's going on, calls us. I assume
You would have acted in good faith. First, you have acted in good faith.
I'd like to act in good faith by their
Yeah, you've acted in good faith. There's nothing you've done.
Is there a thing that says I've taken my VAD medication, please don't resuscitate me?
I mean, we would hope that people don't do it just like that. That they actually, for example, contact their contact person, they contact their doctor, contact staff, tell the rest of the family. And you know, we're supposed to be talking about good deaths here. And hopefully people are actually doing it, you know, with their family support.
Yeah.
And also that they do set up these things like a 7-step pathway and a ACD, which is available at the time, not because it's saying that they want to follow through, but they write down that they don't want resuscitation.
Well, again, just to offer them that dignity of accommodating their wishes. I guess that comes down to part of the education provided by their medical practitioner when you're going through that process.
And so a lot of it, there is actually some, I mean, we have these tools here, so that's the thing. So, but yeah, it's the sort of thing that is actually sort of, you know, most they're going to be fine. I mean, most are going to set it up properly. They're going to set it up. They're going to tell the family. They're going to tell. But there is, I mean, and look, these situations in hospitals or aged care facilities are hopefully the vast majority occur at home in Victoria under very similar legislation. So we're probably less concerned about what we're more worried about is that, you know, there may be the odd one that's going to scare everybody, or that you know, people are going to be so scared about it, paranoid about it, they don't get involved when they could get involved if they want to be involved as well.
Yeah.
Chris, I might just interject this. I mean, it's fascinating, and obviously there's everybody's clearly interested. It impacts on everybody. So I've kind of just let it run. We haven't got much longer to go. I mean, the plan is to finish at 7:45. There's another excellent question from Jennifer, which is about, you know, this differentiation between 6 months and 12 months for neurodegenerative problems. And of course, there are some people with neurodegenerative problems that can linger on quite some time and still have capacity, and that difficulty around prognosis. Can you maybe talk to that?
Okay, so the first thing I'd say is the legislation is legislation. It was written as a starting point. So I don't make any judgment about it. My job is not to actually. What I would say is that the 6 months was for, you know, just it was for a safety point of view, and then the 12 months for neurodegenerative conditions. I totally understand this issue about MS and Friedreich's ataxia and those conditions, about whether there's uncertainty about it. Now, that's obviously why you need a specialist involved. For the 12-month one, you actually need a specialist in that area to provide a prognosis. So that's very important for the neurodegenerative conditions. Now, the thing is that people are always going to be, I mean, you know how when you do research, there's always a type A, type B, false positive, false negative result. You know, the bottom line with this is whatever you do, it's either going to be too strict or it's not going to be strict enough. And, you know, like a patient came to me the other day and said something like, you know, look, it's not fair because I can't get it because I've got this condition, and the mental health condition, and mental health conditions are not allowed. You can't get VAD under this. It's not fair that I can't get it because, but I've got to say, this woman is probably going to die. Let's just say, very high, very good chance of dying. She got really mad at me. Then I had to explain to her, but look, the reason why they did this is they were worried about the situation where somebody has depression for 2 weeks and they ask for it. Right? So if you make it too loose, you catch too many people who are probably not totally appropriate, and you make it too strict, you might going to miss some the other way. And to some degree, that's where we are at the moment. And I don't think there is any subtleties to this. This is a starting point. There is a review of the legislation in several years, and the review board will be taking information about this over time. And look, there's definitely, I mean, you probably heard even in my voice, the things we've had to overcome to try and get us to this point. There's a lot of things which are really quite complex, which we've had to overcome to try and get to this point, to try and get to this moment. Could I just say, just one point, there is actually there's a conference, you can look it up. There's actually a conference for all healthcare workers on the 16th, so it's next Wednesday, and it will actually be going through some cases and experts from interstate that have been there, people from the pharmacy service, care navigator service, just talking about various aspects. Roger Hunt will be there. He'll be talking from his perspective because he's driven a lot of this.
Is this SA Health that's running?
Yes, SA Health. Yeah, the minister will be from this. It's an online one. If I know we don't all
For
have.
any practitioner?
Sorry?
Is it for any?
Yeah, or any health practitioners. So you can all log in.
I think I've got the link that I might add it to.
Yeah,
this
and the other thing to
and,
keep in mind is there'll be a recording of it, and you
Yeah.
can get in. We're trying to get some of the healthcare, aged care people involved as well, because that's a very big complex area for us at the moment. But if you really want to know a little bit more about it, next Wednesday on the 16th will be big. I think we're expecting quite a few hundred people on board from all different areas. Because as I said, I hope you kind of understand now what I've said here. This is like a train coming, and for my job has been to make sure we get the balance of choice and access and equity, but also safety. But it's going to affect everyone. Even though in the end, maybe 1% of the population may actually only be accessing this who are dying.
Interesting to see how it all transpires. We're very lucky to have you talking to us, which is why I just sort of let it run, because it's so fascinating. We have, and it's been informed by some cases, as you were sort of talking about, some more practical questions. I might just, before we finish, because I don't think we've got enough time to go to a case, because I really think it's been, what you presented has been very practical anyway. We can probably think of our own cases that we can mesh with what you've talked to us about tonight. I'm just wondering, and I've got this Sue Haynes is on the line, and of course Olivia and Julian, whether you guys have got anything to contribute around this area, the second talk around VAD and the complexities that might have, the challenges that might have for palliative care, but also Chris's first talk about 7-step and advanced care directives and preparing and planning for end of life. Maybe Sue, you got anything that you want to add? Sorry to put you on the spot. I'll take that as a possible no.
I don't know if you need
Yeah. Olivia, what about you?
Oh, look, I'll just firstly say thank you to Chris for presenting. That was absolutely fantastic. And I work in this space, but it's so good to just have a refresh of the legislation and get that really at the front of that mind, and really that confidence and that protection to provide the care that we do to our patients that are often very vulnerable. I think I feel like I'm such a new player in this space, but just my one thought is, when I'm talking to patients about advanced care directives and who they want to nominate, and I try to be a bit careful with my language, and it's called a substitute decision maker, but I always frame it in a space that is a decision maker to uphold the idea of the patient and to assist a doctor in making decisions, and not really giving that permission to, completely override a doctor's opinion and to enforce futile treatment. So I think the term is good, but I think there's scope for misunderstanding in that. I don't know, Chris, if you have any opinion about that.
I agree. I think a collaborative approach is much better. So sometimes that terminology does seem very confronting. But to the same degree, I think that they do need to understand their role is really to put themselves in the patient's shoes and actually try to do what the patient wants at all times.
Thanks, Olivia. Sue.
Sorry, Russell, I've just worked out how to get myself off mute. I'm just working off my phone at the moment, so I've been listening with great
Probably my apologies.
Chris. Fantastic summary of what's going on. Yeah, and I don't know if I have anything to add to what you said.
Okay, thank you. And Julian, from a point of view of a pharmacist.
Well, I was going to put my aged care hat on. I think Chris covered most things. He's obviously quite across a lot of what's happening. But speaking in regards to the 7-step, it's an interesting phenomenon. And I think from my experience, it's very GP driven, depending on sort of how many 7 steps get done. Like I've been across 2 facilities. One, maybe 90% of the residents had a 7-step, and it was fantastic. And others not so much. So yeah, it's interesting to sort of see that, and they're just really useful when they're there. And I think Andrew kind of mentioned it earlier too. When those are in place and everyone's on the same page, it's really streamlined. And the goal at the end of the day is, residents don't go to the hospital as often, which a lot of them is their goal. So yeah, definitely a big tick there is the uptake of advanced care directives and 7 steps. Yeah, and then Chris has pointed out BAD and aged care is something that we're all a bit concerned about. That sort of someone's brought it in their suitcase and you find them deceased one morning, but it's something we're kind of working towards. And our understanding is it's going to be very, very few cases in aged care, so we're not expecting a huge maybe workload, but yeah, that you don't want to be the nursing home dealing with that one case, I guess.
All right, so as you said, Chris, the train is coming. It's arriving very soon. So we get on for the ride next year and see what happens. Yeah, but as you said, there's going to be a review in a few years' time. So look, thank you again. Absolutely fantastic to have you here and to share your knowledge, your inside knowledge about all this process. It's been brilliant. And
So yeah, 16th, if you want to know a little bit more. I really think for a lot of us, it's a great idea to be there just to get a sense of what's about to happen.
That's really good. So we'll put links to that on the website.
Yep.
And once again, thank everybody for joining us tonight. Been really interesting, fascinating talk. And just to remind you, so our next session's early December. I've forgotten the date.
7th, I think it is. 7th of December.
Around the 7th. We'll send you reminders. But please send us. We didn't get to a case tonight because I think it was.
I talked too much.
No. It was way more to talk about, both VAD and the 7 steps. But please send your cases in, and we look forward to seeing you online next time.
On the 7th,
Leanne, anything else that I've forgotten about?
No, I think that's all good. Just encourage you to pop onto the GP Partners Australia website, where you'll be able to click on the Palliative Echo page and all the resources will be there. And as always, if you do need any assistance, any help at all, we're able to, if we can't help ourselves, we'll certainly find someone that can help you in this space. So thank you for attending tonight, and thanks to the team. And again, thank you, Chris.
See you folks.
Good night.
Bye.